I'm Hernán Trimarchi. I'm a nephrologist based in Buenos Aires, Argentina. I work at the British Hospital, and I'm here for the WCN 25 held in New Delhi, India. I'm a member of the working group of the KDIGO IgAN Nephropathy guideline. So, in this new 2025 KDIGO guidelines, there are some key points that for me are the most important. One is early detection and the aggressiveness of treat patients accordingly regarding these. If you detect early, it's because you have to do a kidney biopsy, which is, the first step to say the patient has IgA nephropathy. The prediction tool is something also important for prognosis aspects. And then the pathophysiological new discoveries regarding inflammation, Gd-IgA1 deposition, and those two will lead to fibrosis. So the earlier we treat those two key drivers, the better it will be for the lifespan of a patient. Kidney biopsy is very important, as I said before, for diagnosis. If you don't have a kidney biopsy, it is impossible to make the diagnosis of IgA nephropathy. In my opinion, kidney biopsy is very important, not only for diagnosis, but also for, some information gives you regarding prognosis. So the MSC score is something that gives you some inputs on the prognosis of this entity regarding mesangial proliferation, if it's there or not, endothelial proliferation, and crescent presence. So those are the inflammatory key drivers. And you also have the sclerosis that some of the subtypes like podocytopathy and tip lesions are more active, you have more proteinuria. So these are the cases in which you should be more aggressive. With most of the time they are also being accompanied by higher levels of proteinuria and most of the times microhematuria, because the microhematuria is telling you replication of cells, cellularity, which is being increased either at the mesangial area and or the endothelial area and or at the extracapillary space. So microhematuria is very important. Follow-up reasons too. Proteinuria levels have to be, taken into consideration for regarding therapy, because the higher the proteinuria, the worse the prognosis is, and then the GFR will start to decrease. So you have to be aggressive from the very beginning, because, as I said before, as long as you have the biopsy, you will know that the patient has IgA nephropathy. From there onwards, you have to follow up the patient. And the sooner you start treating, as I said before, the better. So this is a lifespan enduring condition. Taking this into consideration, one of the things that we can also do for the patients is to use the prediction tool. There are two predictions tools. One is for the time of at biopsy. The other one is the post-biopsy one. But let's go for the at biopsy prediction tool, which is the most used worldwide. So here it is very easy to use. It's an app you can put in your phone, and then you can do it during routine visits with patients when they have the biopsy data. So many times they come with their family. So they want to know, which is the prognosis of this? What are we going to do with this? How is our kid, or how am I going to be treated? What can we do for me? What can you do for me? So you just have to upload some variables like serum creatinine, proteinuria levels. Also, if you are on RAS inhibition or not, if the patient has already been immunosuppressed, ethnicity, and also the what we call the MESTC, or the Oxford score. With that data that you get from the biopsy, and all this information will give you some prognosis about which is the chance of you developing stage kidney disease at around 80 months. So maybe it's 50%, it's 5%, it depends on the patient, and also on what you will do afterwards. So this is very important for an early detection, also to give you like a whole landscape, or where you can launch your therapy and therapeutic approach to these patients. As I said before, this has to be a customized therapy approach in which, as we say in the guidelines, in all the guidelines, you also have to go for the nephroprotection, which is important. But also you have to think now, because from 2021 till now, things have changed regarding therapy. So we can also approach the key drivers of IgA nephropathy. But before that, which is not enough, but is necessary, is to take into account those nephroprotective measures like blood pressure control, sugar control, exercise, tobacco use, you have to avoid it. Use of RAS inhibition, as long as you have 0.5 grams of proteinuria or higher. And all those things that we recommend patients to do besides then what we're going to do with the key drivers if we have the chance to use them in due time. So these patients start with the disease early in childhood with minor amounts of proteinuria, but before that you have microhematuria, which is something that most of the time is being overlooked by pediatricians. And this is the first thing we have to take into account. So the earlier the diagnosis, the better. If you come to have microhematuria a long time, you should also follow up that patient because sometimes minor amounts of proteinuria will start to appear. And that is when, the red light should be turned on. Then you also have patients who have microhematuria plus proteinuria from the early beginning. You can have nephrotic syndrome. You can have different amounts of proteinuria in different patients or in the same patients at different stages of the disease. And you can also have RPCN. So I think that education to general practitioners and to pediatricians is very important because this is where the story starts. Because if we don't do an early intervention at that stage of life, then when patients become adults, we have already lost a lot of time when things could have been prevented. And then we have CKD, we have stage kidney disease. For instance, if you look at the RADAR study published some months ago, you will find that, for instance, in patients who have an UPCR of 0.44 to 0.88 grams per gram, around 30% of patients will end up with end-stage kidney disease by around 10 years of time. And even if you have 0.44 gram per gram of UPCR, 20% will end up with end-stage kidney disease at 10 years' time. So in the first cohort, 0.44 to 0.88 that I have been talking to before, at around 15 years from diagnosis, 50% of those patients will end up with end-stage kidney disease, either transplantation or dialysis, which is something that if we have an early intervention from the beginning, then we will have better results. So the recommendations vary. You have a bunch of recommendations to be shared with the community, but then it depends on where you are. Even in the same country, you can work in a poor area, or you can work in a high level, rich area. And also it depends not only on the education that we as physicians have, but also on the education of the family and of the patient. I live in a low middle income country, and the region. Most of these drugs, sometimes they are not affordable at all. So that is something that is very important to address. The guidelines are telling us there are new drugs. And we suggest that according to pathophysiological findings, these are the drugs that have to be used. And there is no question about that. The thing is how we implement this in the 80% of the world where these things cannot happen. There are some universal general recommendations that are quoted cheap, not so easy sometimes, like to lose weight, which is something that is cheaper than anything, but it's not easy to take into practice. Then the blood pressure control is something which is really important in the long term. It will have a long-term effect. If patients are diabetic, you have to put the blood sugar as low as possible, regarding within normal limits. And also you have to educate people, to avoid salt, which is everywhere. So this is something that is universal. So there are no issues with it. The more you are compliant to this, the better it will be for you in the future, most of the time. Sometimes, despite this, if you have an aggressive disease, this is not enough. For what we say inflammation, what we have is steroids. Steroids are worldwide used. They have a lot of side effects, particularly in kids, due to obesity, the risk you run to have diabetes in the future, blood pressure. Then you say, okay, are we gonna give the patient steroids, which is something that most of the time is being done in low middle income countries, or we should put the patient on an RCT, which is the best way. This is a very important recommendation by the guidelines. We're still doing that. So this is a problem because RCTs are not run in all the countries. They're run most of the times in maybe 15, 20 countries from always is states present. European countries vary, but they are always present as a continent. Then you have Asian. We never have Africa. And we are starting to have Latin America, maybe 2 or 3 countries, Argentina, Brazil, sometimes Colombia, sometimes Mexico, and that's it. So from the logistical point of view, we have a lot of pending situations that we have to improve. And this has to be done with a lot of actors being present. First of all, I mean, national policies, health system policies have to be taken into this game, say it this way, to work together, because we have to work as a team. Then we have the national societies, which are the ones that should address the national government. These are the recommendations we need for our people. Then you have industry. They are the ones that, bring up, these are the drugs that we're offering for the patients worldwide. Then we have the sites, I mean the hospitals. And in the middle of that, you have patients, which is the most important. That they are what we are taking care of. They are taking care of patients, of human beings. So if you run an RCT, it is not available everywhere. That is a problem. So we have to run the trials in more countries. But for that, you have to have sites that are prepared for. I mean, logistically, they know how to run a trial. Do they follow GCPs? Do they have all the implementations we need for the samples to be taken the way they should? Are the eligibility criteria being followed up by the sites and being controlled in a good way by the CROs, and the sponsor is being, around that, and then the national regulatory agencies are taking care of this, because the patient is the most important thing here. So we need a lot of education, and industry has to be also aware that if you run an RCT and then you leave the country after the OLE finishes, what we need is that until the drug is available in that country, those patients who have taken benefit of this RCT, of this drug, should be being given the drug until the drug has been approved in that country. I think that we need more support from the national governments, from national societies, but mainly from the industry, to go to all these low middle income countries for education and also for research, so that these people can take advantage of these new discoveries, as the KDIGO guidelines are distributed all over the world. So this will be a more fair world for everybody.